Hi everyone. Let's talk about angina or angina, as some people also pronounce it as. It's going to be like a second part of the coronary artery disease lecture because they kind of go hand on hand in a way. I just wanted to make separate lectures in case you wanted to see them in two different videos. But I will be referring to some of the items in this lecture to the coronary artery disease lecture. All right, well, what is angina? So, angina is really a symptom, okay, guys? It's a symptom related to something that happens in the heart where the muscle is aching due to the lack of oxygen and it hurts. So angina equals pain, okay? The muscle, the heart is aching, it's hurting. So the muscle, any muscle, but specifically in this instance, we're talking about the heart, requires this demand of oxygen and nutrients. And whenever the coronary arteries are blocked or narrow and are not receiving enough blood, then yeah, the blood doesn't reach the muscle, the nutrients don't reach the muscle, and that's when you start feeling angina or angina, this pressure, tightness, and heaviness that can radiate to the shoulders, back, jaw, as well as the arm. Now, some patients, what they have is chronic stable angina, and this is sort of like an intermittent chest pain that is provoked or it's elicited by physical exertion or stress, or if you are climbing a stair and you're huffing and puffing, when the demand of oxygen increases and basically it's not the oxygen is not reaching that muscle. This is the only thing we're going to focus in adult. We don't focus on unstable angina, neither myocardial infarction, which is a heart attack. However, I will sort of say a few things about them just because I have to sort of say them in order to talk about angina and chronic stable angina. Um, so let's define what an MI. An MI differentiates from coronary artery disease or angina in the fact that when a heart attack happens, the vessel, the artery of the heart completely is blocked and it impedes the blood flow. So that causes the death of the tissue, the death of the heart muscle. That's what an MI is. Now, stable angina usually resolves when the activity is stopped, when the demand of oxygen is decreased, or when someone gets medication. And it usually lasts 5 minutes or less. It's intermittent. So now, if it's constant and it's not relieved with rest, then we possibly could be having a unstable angina. Now, in general, how do we diagnose heart problems? And this is coronary artery or unstable angina or an MI. This is just in general heart issues, cardiac problems. Well, we can get an EKG that can tell us the cardiac rhythm. It can tell us the electrical impulses. It can diagnose dysrhythmias. It can tell us if we have ischemia within the muscle of the heart. And now technology has advanced so great that we have implantable cardiac monitors where it's implanted under the skin and patients can even see their rhythm through their cell phone and it's sent to their doctor as well. Patients can also get a stress test. That's just kind of putting the client on a treadmill or a bicycle connected to a Holter monitor that monitors the electricity of the heart. And basically, they make them excel, they make them heart rate goes up, and they'll see if there's ischemic changes within the muscle. If basically the patient is not getting that oxygen to the actual muscle of the heart. An echocardiogram, and I have pictures of this. An echocardiogram is a ultrasound visual of the internal aspect of the heart. You'll see your chambers, your atrium, your ventricles, your valves, and how does the blood flow through those chambers. We also look at something called cardiac enzymes. There's two different ones. One is troponin, which is the indicator for a myocardial infarction or whenever there's death tissue of the heart. And then we look at creatinine kinase and B, that is whenever the muscle has been damaged, it's released into the bloodstream. And last but not least, we can do an angiography of the coronary arteries. Basically, they inject some dye and they can actually see blood flow of those arteries with a lot of x-rays and whatnot. Here's the implantable cardiac monitor that I was referring. It almost looks like a little USB and is implanted underneath and sends the electrical conduction of the heart to their doctor in your phone. So when someone says an electrocardiogram, think of electricity. That's your regular EKG uh, sign that we all sort of relay, the common population relates to life. It's the QRS, basically. And then when you hear echo, like echo, woo, echo, well, that's kind of the visualizing inside of the heart, just as this picture shows here, the ventricles, the atriums, and the valves, and how they move. So, what can we do when someone has chronic stable angina? Well, what we want to do is increase that oxygen demand. Um, we know the muscle is aching, it's hurting because it's not receiving enough oxygen for the demand, the stress, or the activity that the client is having. So, if we can increase that demand of oxygen, our symptom, our angina, will decrease. So the first thing we got to do is prevent those risk factors that leads to arteries being narrow. So a lot of education on diet, of not saturated fats, lowering your bad cholesterol, increasing your good cholesterol, lowering your triglycerides, as well as exercise. Managing your diabetes, avoiding smoking, alcohol, obesity, etc. Now, we do have some medications, antiplatelets. They basically inhibit platelets like aspirin and clopidogrel. And so, if the artery is narrow because of plaque, then I don't want platelets aggregating on that plaque and basically blocking completely the blood flow. So I can inhibit those platelets with an antiplatelet and decrease the risk. We also have cholesterol reducers, and these will reduce the cholesterol. And then we have ACE inhibitors and ARBs, as well as beta blockers and calcium channel blockers to basically relax the smooth muscle within the artery, as well as decreasing the frequency of the heart. And you will find how they work in the hypertension medication lecture. Specifically for angina, yes, we can give all this, but what's going to work the best are your nitrates. They're your dilators. Um, just as we had bronchodilators for our airway, we have nitrates for our blood vessels. And this picture here shows you how a normal vessel, size, and then you give them a nitrate and how they puff up and they get big and they dilate. Now, in instances, a nitrate might not be sufficient, and the patient might need or might require, we'll say, what might require um, a percutaneous transluminant coronary angioplasty, a hard cath with a stent, where they go in and they get to where the plaque is, and they put a stent after they kind of smash that plaque and open up the vessel. And I'll go over that in just a little bit. Or if the vessel, the artery in this case, is completely blocked or not reachable, they might have to do a coronary artery bypass graft where they're rerouting the blood flow. Let's look a little bit more in depth about nitrates. Well, they're very powerful dilators. They relax the smooth muscle. They work on all vessels, okay, guys? So large, small, everything. And they basically increase oxygen demand, okay? Not demand, sorry, oxygen delivery. It decreases oxygen demand. So it makes the oxygen molecules reach that muscle, if because more red blood cells are going to be traveling. Um, they're used to prevent and treat angina, and the one that we love and we use most is nitroglycerin. Now, nitroglycerin can be sublingual, it could be IV, it could be transdermal, ointment. There's a spray that goes under your tongue, but usually the one that you sort of see more for angina are your little bitty pills that come in a little bitty vial that they go under your tongue. They're sublingual. Now, I just want you to note and just maybe make a note there that we do have long-acting nitrates. A common one that we use is esobarbate. Um, isosorbide. That's how you say it. Isosorbide monotrate, commonly known as IMDOR, IMDUR, and they are used to prevent anginal episodes. So you might see nitroglycerins for like an acute, like right now I'm having this chest pain, but then maybe the patient be taking a long-acting form. All right, here's that little bitty bitty bottle that I was talking to you about, that little vial. It's actually a little bottle. It's colored like that. It's brown because nitroglycerin is sensitive to the light. So it needs to be stored and kept sort of in a dark vial like this. They are very powerful, and so they relieve the pain in about 5 minutes, and they can last about 30 to 40 minutes in the system. So the instructions are that you take one tablet, and if symptoms are unchanged or they get worse, you should call 911 after those 5 minutes because it should relieve your symptoms, the client's symptoms, especially if they have stopped the activity. Um, they should tingle whenever the clients put it under their tongue. If it doesn't tingle, then that means they lost their effectiveness and they're not powerful anymore. They should be replaced. The bottle should be replaced after 6 months of opening it. They lose their potency if they're not. And because they cause lots and heavy, very potent vasodilation, clients could experience orthostatic hypertension, headaches, dizziness, and flushing, and should not be given with erectile dysfunction medication because you're double giving vasodilation medications. So some of the things that you want to teach is Do not combine them with erectile dysfunction meds. Sit down if you're going to take it, or lay down, or if you're laying down, sit first before you stand because it could cause orthostatic hypotension. Think about safety with these clients. They could get dizzy very quickly. You also want to tell them that they should take it if they anticipate a various, like an activity that is going to require them to have a big oxygen demand. Like, let's say, let me give you a scenario. Let's say, trying to think over here. Okay, oh yeah, let's say that it's Sunday and you're gonna mow the yard. Well, it's hot, right? It's hot in Texas. Mowing the yard is usually not that easy. You got to push the lawnmower, et cetera, et cetera. Well, that's an activity that your heart is going to require a little bit more oxygen in your muscles. So, therefore, you might want to take a nitro before you do that. Or let's say you're going to be putting up groceries and you got to climb some stairs. Again, that's another exertion activity. All right, so general interventions. We want to help these clients with ADLs. We want to avoid fatigue. We want to monitor their vital signs, especially for that orthostatic hypertension, as well as their heart rate. We want to monitor their cardiac rhythm to make sure that they don't change from chronic stable angina and now it becomes like an unstable angina or an MI. We want to elevate the head of the bed and administer oxygen as needed. Encourage the clients to maintain that cardiac healthy diet. Uh, you want to educate them to avoid extreme weathers, like especially hot weathers, because hot dilates and you're already taking a dilator. So again, your blood pressure can drop or plummet. Do not eat large or heavy meals and rest after eating. And also promote their feelings, especially after someone has had an MI or a coronary artery stent. They tend to feel like, oh my God, I almost lost my life. And some go into depression or, they just feel scared. So we do want to promote them discussing their feelings. Let's talk about the heart cath with stent. Usually, this is a minimal invasive procedure that the physician goes in through the groin or the radial artery and goes up to the coronary artery that needs the blockage, or they want to visualize for blockage, and either smash, remove the plaque, or as place a stent. And by placing the stent, it makes sure it keeps the artery open, allowing blood flow to the heart muscle. Now, whenever they go through the groin, they are injecting a dye, like an ink, and taking x-rays. That way, the physician is guided to exactly where he wants to go. The stents are metal only, or they're drug eluting stents, which what that means is that it prevents this overgrowth of tissue within the stent. After a procedure like this, guys, patients are on aspirin, um, antiplatelet medications like aspirin or Plavix. Some of the things that we do want to watch out for after a stent placement or heart cath is that, because especially through the groin, okay, through that femoral artery, you want to put pressure on there. They're usually in bed for a few hours. Um, you want to monitor for hematoma. You want to discourage the client from moving or bending that leg a lot until it clots, because the puncture side is very big actually, okay? You want to monitor their cardiac rhythm. Whenever you go up to the heart with a stent, and a catheter, it can aggravate the nerves and it aggravates the heart. And so patients can go into arrhythmias, which might not be very healthy arrhythmias, okay? And so we want to do EKGs, telemonitoring um, of the chest, and taking vital signs very often. We also take vital signs to monitor if perhaps accidentally the physician punctured something, okay, or dissected maybe an artery. Your blood pressure will plummet, and so vital signs can tell us that as well. Because they're going through the artery of the groin or the radial artery, you do want to monitor neurovasculars. Um, Distal to that extremity. And let's talk about neurovasculars a little bit. Neurovasculars, we're talking about color of the extremity, like is it blue or pink? Um, the pulses. Then you're also looking at paresthesia. Does it feel tingly? Can they move? Paralysis and pain. Let me see if I got all of them. Pain, paresthesia, pallor, pulses, and pallor. Oh, and temperature. We do monitor temperature as well. Is it cold or kind of warm? Because all of that, it's telling us it's perfused. We have perfusion, and we want to do that for every 15 minutes, okay? 15 minutes, every 15 minutes for the hematoma check, every 15 minutes for the neurovasculars. I didn't mention all the complications that could happen. I did say, well, maybe the physician could accidentally dissect an artery, but also think about clients that might be allergic to the dye that they put in. So you might have some allergic reactions. You might have even kidney function being compromised. So the kidney filters this dye, and so therefore, after the procedure, because they're injecting so much dye, we need to flush these clients with fluid. So if initially they might give them IV fluids, but then they'll transition them to PO, and we want to encourage them to drink so kidneys don't get compromised. And also infection, you're puncturing a very important artery in your femoral groin area. It could get infected for sure. Here's kind of how it looks, like a angiography, how it sort of looks with the x-rays and the dye, the catheter coming up, and you can see the narrow spot here because it's not as thick as the other one. That's how you know that there's a blockage. Okay, this is the coronary artery bypass. Now, back in the day, we used to do cabbages, or we call them cabbages, guys, cabbage, as an abbreviation. Um, Traditionally, back in the day, they used to do these like open heart surgery. They basically cut the sternum, open the chest cavity, and then they bypass your blood flow through a machine, to basically diverting that to a machine so it could be oxygenated and put back into the client. Well, now they're actually doing this in a less invasive form. The book talks about it a little bit. So not necessarily kind of like big open chest and bypassing blood and running it through a machine. But the traditional ones, they you might have a graft that maybe they get from a different part of your body, or it's artificial, and they'll bypass it, like in the sample here, from your aorta to that coronary artery that it is blocked below the blockage. Okay, so basically you're bypassing the blockage. And then I wanted to show you this. So I mentioned that nowadays we're going through the risk. Before, back in the day, was only through the femoral. Well, they've come a long way, and now we can go through the artery of the wrist, the radial artery. And when they go through that, it's a little bit less bleeding, okay? Less risk bleeding, less, it's a smaller artery, as well as, you're not bending that leg with the femoral. Um, and so they put these sort of like cuff. You inflate the cuff and it puts pressure on the artery puncture side of the radial artery, healing a little bit faster, and patients can be mobile with their feet. So it's kind of handy, actually. It's kind of handy and clever. And so, but navigating, of course, that catheter up to the heart, as you can see in the picture here below, um, you know, it might be a little challenging because you got to go through the whole arm. All right, well, that's angina. And again, let me refresh, let me go back. Angina happens as a symptom from a blocked artery or a semi-blocked artery, not complete blocked, but just this artery that is narrow, and blood flow is not sufficient, oxygen is not sufficient to meet the demand of the heart. Once you stop the activity, it should subside. If you take medication, it should subside. And then we have that nitroglycerin and other whatchamacallem, procedures that we can do to sort of unclog an artery and restore blood flow within the heart. Okay, here are my references as always. I hope this was helpful, and I will see you in the next video. Bye-bye.